Video will be addressing some of the lab questions that we didn't quite get to that I want to wrap up and just make sure we were clear on. So I wanted to start with this number 9 really quickly. What is the effect of tibial rotation on cruciate and collateral ligaments in the knee? Which ligaments primarily restrict internal rotation and external rotation? I wrote this down here. So tibial rotation can increase or decrease tension on the knee ligaments in general. So the ACL, this is what I want to make clear here. I want to come to this image here. All four of these ligaments, the MCL, the LCL, the ACL, and the PCL, all four of these are going to help resist internal and external rotation to a point. They're all going to play a role. But if you look at the orientation of the ACL and the PCL and the PCL, you can see how they're already oriented in a medial type of fashion. They're directed medially at their restraining ends, maybe is the best way to say that. So you can imagine if this tibia internally rotates, I hope you can look at this image and think, oh, that ACL and that PCL are going to tauten more quickly than the LCL and the MCL. So while those cruciate ligaments, they help stop translation of the tibia and the femur in the anterior and posterior direction, they also resist forces in the transverse direction, particularly with internal rotation. And I hope that as you look at this, you can kind of see that. Again, if I pull this tibia and internally rotate it here, it's going to quickly tighten that ACL and that PCL, which is why one of the mechanisms of injury, a part of the mechanism of injury for an ACL tear, is a valgus stress with an internal rotation. You can imagine that ACL just really tightening quickly and eventually getting to the point that it can't withstand the stress and therefore it ruptures. Okay? So conversely, the LCL and the MCL, they are going to specifically tighten more quickly when that tibia goes into an external rotation. Particularly this LCL is attached here at the fibula, it's going to tighten fairly quickly. So I'll come back to the lab here. So the ACL and PCL resist both internal and external rotation to a point, but particularly they tighten quicker during internal rotation. So I wrote that down. LCL and MCL limit external rotation quicker than they do internal rotation. So hopefully that makes sense. If it doesn't, just go and Google these images and kind of look at this for a while. Kind of look at it, create it on your hand, and it'll help you hopefully visualize that and see that a little better. Okay, we're gonna move down into some of these tests. So on number 12, I felt like because we did this in the spine and the hip lab, I thought you might be able to already assess the ASIS, the PSIS, the CRESS, ischial tuberosity. We didn't talk about the pubic tubercle. You can look at that on yourself. So I just went right into B. So this scour test, what is being assessed? This is an image here of the scour test. So what you're doing is you're going to compress this hip. So what you're doing is you're compressing this the femoral head into the acetabulum in many different directions. So what you're going to do is you're going to push it posteriorly, you'll push it medially, in lots of different directions. And what you're looking for is any roughness in the joint. So you're looking for potentially hip osteoarthritis in an older individual, or in a younger individual, you can use this test to assess for a hip labral tear. And I didn't pull that up, but we can quickly find one. Here, if I go to these images, so if we look here, that labral tear, so when we do this scour test, what we're doing is we're hoping to reproduce symptoms kind of similar to a meniscus, where you're looking to see if you can find some clicking or some popping or some pain in those extreme ranges of motion as you push that femoral head into that acetabulum. Next up is the straight leg raise test. So it just asks simply what structures are being assessed. The straight leg test is exactly as it sounds. You're having the person lay on a table. You're going to have the knee extended to 0 degrees or 180 degrees, whichever you prefer. And then all you're going to have them do is lift the leg from the hip. Okay? So if the person is actively raising the leg themselves, then what you're doing is you're assessing the musculature in the hip, particularly the hip flexors, the iliopsoas and the rectus femoris. If you're doing it passively, then you could also use this test to assess the neural sheath, similar to the slump test. And so you can have it check for neural sheath defects. And if you do that, then you would passively raise the person's leg up, looking for pain at various points along that neural sheath. So either one of those, depending on how you use that straight leg test, either one of those is what you're going to be assessing for. A couple more, so 3 more on this. The next one up is Faber's test. You can see this here. Faber is for flexion, abduction, and external rotation. Flexion, abduction, and external rotation at the hip. So, or you can, this is also known as the figure 4, because you're just creating a figure 4 at the hip. So this is a general test, and I should include this, and for SI joint pathology. So you're testing for hip mobility, you're testing for general hip flexibility. So if this person can't bring this knee down, if it's straight up, or if they experience pain while they're going down, you could also imagine how this is going to really compress that SI joint on the posterior side. Thereby, you can potentially be testing SI joint pathology. You can test all 3 of those, and it's just a matter of where the person experiences their pain during this test. So it just depends on what they feel and what you're kind of looking for. So that's Faber's test. Next up is a Thomas test. So a Thomas test, you can see here, you're just going to have the person come to the edge of a table. You'll have them bring one knee up to their chest, and they'll fall back. What you're looking for is to see if those hip flexors maintain some tightness, and I've got an image on this here. So you're just looking to see if the person maintains some tightness in those hip flexors. You can also use this test to assess for IT band. So what you'll do is you'll just come to the end of the table. You'll look and see, does this hip pick up, the hip that's supposed to be laying on the table, does it lift up or does it lag out as the person brings this one up? Both of those will just give you a general indication of the person's flexibility at the hip, in the hip flexors or the IT band, either way. So I wrote that here. Thomas test, hip flexors, and potentially IT band, depending on what you're looking at. The last one is Ober's test. I've got a video on this one here. So what you're going to be looking for here is you're going to stabilize at the pelvis. You're going to just bring the affected leg back and lower it down. So I'll pause that there. So I actually wanted to say a little bit more about this IT band as we get into this special test. So what you're looking for is to see if this leg will drop, if it will come down, or if the person experiences pain along that IT band. So I wanted to look at this, a couple of things here. So remember, your IT band is just a really thick band of tissue that comes down. It goes from right here, the iliac crest, and it goes down to the lateral tubercle of the tibia. Particularly, it's going to extend over the lateral femoral condyle, right there. That's the site of the reproduction of pain for most people. So you can imagine in a tight IT band, it won't allow that leg to drop down, right? Or it may reproduce symptoms, and they may begin to develop some pain as you try to drop that knee down. So that IT band is a lateral stabilizer. It also plays a role during extension in helping to lock out the knee. So both of those things are important. There's some ideas about this IT band. A lot of people think it's a friction syndrome, especially when the pain is at that lateral femoral condyle here, where they feel like that IT band is just rubbing back and forth, and as a result of that rubbing, it has become inflamed and thereby is causing pain. But it may be, you may have some increased pronation with that. You may have some knee valgus. There's some different things that we would look at here in regards to the IT band syndrome and its causes. for me, I used to look a lot at increases in activity, right? If a person went from not attending practice to going to practice 3 hours a day, this IT band friction syndrome, or IT band syndrome is probably the better term, that is not uncommon. So treatments for this, some stretching. I particularly like this stretch here. I know Dr. Mitchell, she would also talk a lot about muscle releases, particularly in that tensor fascia lata and at the glute medius and minimus. So there's a couple ideas. So now coming back, that will hopefully make a little bit more sense what we're looking at for here with the Ober's. So we're allowing that to drop, and we're looking at for some reproduction of symptoms as we drop this leg. Another thing that you can do here, and I think this guy will do it, he's going to have them just bend their knee. And they're going to look to see if that knee continues to drop, or if it doesn't, if it comes up and tries to maintain that position. So that's Ober's test, IT for IT. And then just scrolling through, I believe, this last one. Yep, I believe that was about it. The last one, what are squinting patella? Frog eye or grasshopper eye patella, femoral anteversion. So I've got an image for this here. This is a good image here of squinting patella. This would be more of a frog eye patella. So remember, your patella sits mainly at the femur. So while your patella tells us some good things about the knee, particularly in this squinting patella and this frog eye patella, it's going to particularly tell us about femoral anteversion and femoral retroversion. So if we have femoral retroversion, that patella is going to sit more laterally, and it's going to look much more like a frog eye, right, where the eyes are up and out. So the patella will be up and out. The squinting eye, right here where they're in, this is going to tell us much more about the anteversion. And hopefully you can kind of imagine that here. Here's another image here. So when we have this anteversion, those patella are going to be in, kind of looking at you. So the answer to this, what are squinting patella, what are frog eye, grasshopper eye patella, and what do these indicate? It's where the patella either look in or they're up and out, and they give you ideas about femoral anteversion and femoral retroversion. And that finishes this video going over a couple of these things left over from the lab.